Hi, everyone. We'll wait just a couple of minutes while a few more people bing bong into the meeting, and then we'll get started. Let me just mention that I have a blocked tear duct, and so my left eye waters all the time. And so if you see me dabbing my eye like this, it's not that I'm moved to tears by your PDSA stories. It's that I've got a blocked tear duct. I'll have to have a little procedure done this fall, I think, to get it unblocked. All right, we're getting close to, I think, the number of people I was expected to be here. So welcome to the learning session. Thank you, everybody, for coming. I'm Lisa Deshay, as I think most of you know, and we're happy you're here. Oops. Here's our agenda for today. Let me go ahead and start this as a slideshow. So we're going to start off today with Dr. Bard going through the baseline data on this project, and particularly looking at things like referrals and so forth, and use of services related to social determinants of health. And then Dr. Tabitha Fleming will be doing a presentation that she and I wrote on substance use screening. Then we'll hear from a couple of your programs about the current PDSA, your story so far. After we take a break, we'll have the next couple of you tell your story, and then we'll break for lunch. And we could end up, if we end before we get through the last story before 11:30, we'll just give you a little extra time for lunch, because 12:30 is when Kayla Woodbury is scheduled to come in and start her Unitas training. After her presentation, we'll take a break, and then we'll be working on the second PDSA for this learning collaborative, and we will that won't start until the first of the year, but we're just going to get a jump on it now and work on it now. And so you'll hear more about that shortly. And then you'll come back into the main room after your breakout rooms with your analysts, and we'll hear a summary from each of you about what you're going to do. And then we'll wind up with some final comments from Dr. Bard. Okay. Dr. Bard, would you like to start?
I would. Thank you, Lisa. I may not be around for those final comments today. I'm warning mostly Lisa for that. I think she'll probably step in and take my role for that. I have a conflict at the tail end of today's appointment, but I do intend to be here all the way through the breakout sessions. We'll bounce around and just be a fly on the wall as you work on the next PDSA. More details on that coming. I know it may sound strange to be developing new PDSAs when we haven't started the PDSAs that you've been crafting for the last several months, but we're really just going to kind of dip our toe into the water for the PDSAs that you'll start in the next cycle that begins in January. All right, but before we get to that, let's talk about a little bit of motivation for the project and a little history here, your history as a program, for some of the outcomes that we're going to pay close attention to. A lot of the outcomes that we're hoping we can move the needle on, as they say, through the change ideas that you have rearing to go. We're going to tie this back into the first 4 objectives of the overall innovation project. I'm just briefly going to mention each of these as review, and then we're going to get into some data, historic data that touches on all 4 of these ideas. The first one, in shorthand, we're talking incoming referrals here. So incoming for the home visiting folks, referrals coming to you, to a home visiting agency. We're really keyed in on the referrals that come to you from our 3 referral network partners, PCAP, Lasso, and Sooner Start. As you'll see in a moment, we went back and looked in the ETO system as best we could to identify any evidence of referrals coming to you since ETO has existed, at least, from either of those referral network partners. And the goal here originally was to increase those numbers by 25%. So we have plotted out the historic counts of referrals coming to you from those referral network partners or partners like them that serve, legal needs or substance use services needs or developmental services broadly. And our hope is that through the concentrated focus on these PDSAs, as well as the utilization of the Unitas portal, that we can see an influx in greater number on the order of 25%. Okay, second objective is outgoing referrals. And these are the ones that I think we're focused on most. They're probably central to the PDSAs that you've developed to date. Although there's a caveat here, as we'll mention in just a moment when I show you some of the data. But again, focused on the 3 referral network partners, looking at the outgoing referrals from your agencies to those service organizations. 30% was what we had set as a realistic benchmark. We thought was a realistic benchmark, seeing an increase of 30%. Our primary focus here, this gets into the caveat, will be on outgoing referrals to these relatively new partnerships with the Lasso program and with PCAP. All of you have had established relationships with Sooner Start historically. We don't anticipate those numbers overnight to jump tremendously. So our main focus for objective 2 here is really these 2 new service agencies and partners with your group. They're not new necessarily, but this relationship with home visiting for many of you is new. So that's going to be the focus of objective 2. The third objective here, and what I've often referred to as the white whale, we've been chasing this one for ages. Many of you have done this before us, and we've had some success with some crude attempts at closing the loop. And by closing the loop, all we're really referencing here is that when you send information out to a referral agency, to a referred agency, that you get some kind of information back from that agency, that there's this bi-directional communication, and that when the services are actually received from that agency, you are notified. So that closure of the loop is something we're also paying very close attention to. We have some descriptive outcomes that we will be following here. There were no hard and fast benchmark data because it's not something that we've been logging or paying close attention to historically, at least not in a structured, documented manner. So you may have had some notes, for instance, from past conversations with your clients that you referred out to agencies, and perhaps buried in those notes is the acknowledgement of service receipt. But we have not done a careful job as a system of logging and tracking that historically. So this will be mostly descriptive. We'll be monitoring improvement over the next year as you get more familiar with the Unitas system, as your referral partners get more familiar with that system, of how many referrals have evidence of loop closure, and the timing of that is also a key indicator that we're looking and hoping improves over the next year. That the lag time between when the referral was issued and when those services were received, or even when the referral is acknowledged, that we see that lag time decline significantly over the coming months. Finally, the fourth objective we want to concentrate on this morning is retention of clients. This is sort of the distal and ultimate goal of the project, that we can make these, we can identify these types of social determinant needs, social determinants of health needs, make an appropriate referral to these effective services from our network partners, have our clients access those services, and sort of the ancillary secondary boost that the program will receive, we hope, is a longer term engagement with these clients. So we are monitoring retention of clients over the next year with a special focus on families that have an indication of referrals in Unitas. Okay, on to the data real quick. And some of this is going to be open for interpretation and discussion with you all. Oh, and I'm realizing I've got new data in front of me. This is excellent. Okay, we've made some changes overnight based on our conversations yesterday. I think everybody knows we had a learning session yesterday with the other half of the collaborative. And these were sort of puzzling data for us. We went back to look to see what evidence is there of referrals coming to home visiting from the Sooner Start program. Andrew, I'm going to call on you now, I guess, to tell me what all might have changed. I can see the blue line is basically the same. So are we still dependent on the demographics form only?
Yes, the only change I made between today and yesterday was so the current, that red line, the yearly goal, previously that represented an average of one incoming referral per month. And you pointed out in email yesterday that was a misunderstanding on my part. We wanted to set that as at a minimum of one referral per year, which comes out to an average of about like 0.83 referrals per month. So that's the new yearly goal. That's the only change I made since yesterday. So the interpretation here is that red line is going to be the goal of the previous 12-month period, or the average of the previous 12-month period, plus 25%, as long as that's non-zero. If the previous 12 months had no actual referrals, then the actual minimum we're setting, the projected goal we're setting, is at least one incoming referral for that year.
Yeah, perfect. Okay, thank you. Let me see if I can unpack that then for the audience here, and let me start by orienting you to the figure, because I know it's relatively noisy. In your top right-hand corner, this is your PAT data. This will be the structure for the next several slides. In the bottom left-hand corner, that's your Safe Care program data. In the bottom right-hand corner, that's your C1 data. The blue line is real data, and we're looking at month to month, going all the way back to August of 2016. I'll explain why we chose that date in just a minute. How many referrals do we see? In this case, that were coming to home visiting agencies that are part of the collaborative from Sooner Start. And you can see here, this one's flatlined. So we're not finding any evidence of that in the demographics form. That's really key to point out. We had a conversation yesterday with the other half of the collaborative that, oh boy, you ought to look at the combined screening form as well. So we're going to do that. For the moment, we've relied on the demographic form. There is an indicator in the demographic form of the referral source. It is a text field. So this is not perfect, but we made our best attempt here to try to call out all of the information that seemed to be referencing Sooner Start. And if we saw any indication of that, then you'll see the blue line actually go up. Oh, I've got it wrong. Let's see, blue line is yearly. Green line is also real data. It is the month-to-month data. The blue line is an average for a given year. Now, back to the August 2016 date. We're in August of 2023. The August is no coincidence here. We wanted to look at yearly performance in ETO and give special focus on the prior year. So August 2022 up to present day. What does performance look like in ETO? And then as we embark on these new PDSAs for the next year, do we see an improvement? So the objectives that I showed you on the last slide, that 25% improvement in incoming referrals, we're looking back primarily at the 2022-2023 performance here, August 2022 to July 2023. What would a 25% increase look like? When it's flatlined like this for the upper right-hand corner, the PAT program, honestly, yes, Andrew, my initial instructions were, let's look at at least one referral per year if none existed, and then an improvement upon that. But that's an awfully low bar for these PDSAs. And we're really hoping that it's much higher than that. Again, these numbers may change when we look at the combined screening form. The sentiments yesterday that were expressed is, oh, we've definitely had more referrals coming from Sooner Start. You're just not going to find it in the demographics form. It's going to be in that combined screening form. So we'll go back and add that data in, and it will probably boost that red line, which is the goal for the next year, at least the one that you see extended out for 2024. But for the moment, it's sort of anybody's guess of, well, what would improvement be? Anything above 0 in the top right-hand corner would be an improvement. But again, that seems like a low bar. In the left-hand side, looks like we only found one referral where it was clearly indicated that Sooner Start was the referral source, at least in the demographic form. So you get a little bit higher of a goal set for 2024 for that particular program. But again, that's a pretty low bar. C1, we're seeing the same thing we do with PT, no indication. And this one makes a lot of sense and maybe ought to be dropped from this objective. Not sure why Sooner Start would be referring families to C1, right? Because they're dealing with clients where kids are already born, and by virtue of that, they're not eligible for C1. So, okay, I've kind of belabored the point here, but I hope that you're now oriented to the chart. Let's look at the next slide.
If I could just jump in and complete a thought that you
Oh, yeah,
were
go ahead.
making. The reason for starting the years in August is that we're awaiting going live with data collection from Unitas, that we have the custom forms containing the program engagement mile markers that you recall you'll have reviewed, and we'll have custom forms that collect that data for the PDSA, and they are saying that they hope to go live on that a week from Friday. So then if we have the data set up so we have the year ending at July, then we can have this beginning of data collection in August as a new year. So.
Yeah, exactly. Thanks for spelling that out, Lisa. You're right. Not everybody has been in those internal meetings, but we're envisioning that your PDSAs officially start this month, because we'll have those customized forms go live, we think, a week from tomorrow. You're going to hear a lot about that, especially in the afternoon training session with our Unitas representative. Okay, objective 1 still, but now we're looking at legal incoming referrals from some sort of legal source, the legal agency. And again, relying on the demographics form only, pulling out keywords from these text fields that we think indicates legal services. If I remember right, lawyer was one that we found. We also found one very specific instance from an LCDA program of where a grandparent needed some legal advice. So there weren't a whole lot beyond that we could find with the various terms that we search for. And you see that indicated here. So again, it's a low bar. We may find more data in the combined screening form. If we do, we'll adapt to these goals that you see for 2024. But for the moment, boy, if we get even a single referral from, let's say, LASSO, that seems like an improvement over the 4 years, 5 years of history that you see before you now. Again, low bar, we're hoping for more. Here it is for substance use. We see something similar. Oddly enough, in the Safe Care program data, we did see a flurry of activity early on, 2016, 2017, but not much since 2018. And so again, the goal for all programs for 2024 is really low. We'll adjust this if we find more data in the combined screening form. And either way, we're hoping that we get some referrals coming in from PCAP in this instance as evidence of improved referral network relationship strength. Okay, next objective. This is the one that we're all keyed in on, particularly for the PDSAs, the outgoing referrals from your agencies to these referral network partners. You see we have more historic activity here. Same pattern, top right-hand corner, we're looking at PAT. Just to walk you through this, the green bar is the month-to-month variation in referrals that are going out, in this case, to Sooner Start. Our data for this is pulled from ETO's referral tracking forms. both the initial form and the follow-up form, as well as the ASQ forms. So we combine those 2 or 3, even if you think about the follow-up referral tracking form as being a separate touch point, to try to determine how many outgoing referrals are there to Sooner Start. So we see that there's been some variation over time. No surprise that we saw some decline activity during the pandemic. That was part of the motivation for this project. And you can see that it seems to be back on the rise. We're hoping for an even greater increase now that Unitas is in place. But, you know, there's a major caveat here, and it's that there's established relationships. We don't anticipate there being radical changes to your screening processes. We're not expecting overnight for, you know, a ton of new kids to be identified with developmental risks. So really, I think if we see a boost here, it's going to be on the documentation side. So we have discovered from our previous learning collaborative that there are definitely some deficiencies in the old way of tracking developmental concerns and referrals. You know, specifically, I remember the LCDA program, and then I think it was CAP Tulsa as well, had previous PDSAs where they had identified, boy, when we run through an ASQ and a child seems to be at developmental risk, and we're ready to make that referral, but the family tells us, oh, we're already getting services, or we had them a year ago. There was no way to cleanly document that in a structured way in ETO. And so that was not reflected in our old numbers. So we anticipate some improvement there with the refined documentation that Unitas will avail. But again, we're not expecting that the referral and screening processes that you've been doing historically are going to radically change overnight. So this is not one we're really focused on heavily for objective number 2, but we are going to look at those data. Let's move on to legal outgoing referrals. What I just said does not apply to these. So we do anticipate that the newness of the relationship with LASSO and this new care coordination electronic service system, Unitas, will create a boost in referrals for families to the program, and we'll see that evident in the data that we pull over the next year. So you can see where the goal falls. It's the red line that hovers above 2024. And for PAT, well, I have to call back on Andrew for this one, so let me see real quick. Andrew, we had decided this would be an exception to the rule for us. I'm going to highlight for you and for everyone else that there are these spikes that occur at roughly the same point in time. Thank you, Lisa, for all 3 programs, which gave us pause as we were putting this together. And then it dawned on us, boy, that's about the time that LASSO came and presented at our Learning Collaborative monthly call. And so we think that that's why we're seeing this boost in referrals to LASSO. Seems unfair to set our next year benchmark based on the average we saw last year, when that average was greatly enhanced by the innovation project. So for this goal, the previous benchmark will not be 2022-23 data. It will be 2021-22 data. Okay, now, Andrew, has this been adjusted yet? Are the goals here adjusted for that?
Not yet.
Okay. All right. So the red bar is a little higher than it probably should be. But what you will see is a 30% increase from the 2021-2022 data reflected in our next monthly call. And that is our hope as a collective collaborative group, that we see that level of referral activity to LASSO in the coming year. Okay, you can see that, you know, historically the numbers have been relatively low. So if we combine all the PAT programs that are involved in the collaborative, there are 5 of those agencies, we're looking at a little over 4 referrals a month that had some indication in the old ETO data of the need for legal consultation. In the bottom left-hand corner for Safe Care, these numbers are actually very similar. I think it was just a slightly higher fraction for and a fraction here that was slightly higher than PAT, but roughly the same counts for a month that were being referred out for some type of legal consultation. And then for C1, the number has fluctuated quite a bit. No surprise that during the pandemic, we see a lot of these referral numbers drop, but so did the client numbers, because the workforce was deployed to be on the front lines of the pandemic response. So anyway, we do expect those numbers to go up, in part because your client numbers are growing rapidly, but also because of the concentrated effort you're going to pour into these PDSAs. And you can see that increase has already begun to appear. Let's see, it looks like the numbers from last year were about 1.5 referrals a month. The boost or the expectation here is that we reach something closer to what the other programs are currently doing, about 4 referrals a month for legal consultation. When you're putting the PDSAs together this afternoon, if LASSO were the one that you choose, my advice or recommendation would be think back to these numbers as you're putting your SMART aim together. So there are 2 C1 programs. If we're hoping to get 4 referrals a month, those programs are roughly the same size. So, you know, a reasonable goal in your SMART aim would be, hey, let's try to get 2 referrals a month to LASSO from all of our clients. If I'm in a PAT program, I'm taking that for a month and now an expectation of 5 with that 30% boost, dividing it by 5, it's roughly 1 referral a month from each of the PAT programs. Okay, objective 2, substance use. We've again seen some activity historically in this area, and we've tried to pull this together from the referral tracking forms only, not the ASQ form, for obvious reasons. And this is what we found. So for PAT program, we're seeing a higher number of referrals go out. For what it's worth, it might have a lot to do with maybe some distinctions between the client populations that are served here. But we're seeing last year, for instance, in the PAT program, that there are roughly 11 referrals going out a month for some type of substance use service. So the expectation next year with that 30% boost is that we land somewhere in the neighborhood of 15 referrals a month. For the Safe Care program, the numbers were a little bit lower, probably because the client numbers are lower. And it looks like the number was around 4.5 or so last year. So the expectation here is that they'd be somewhere in the neighborhood of 5 a month. For the C1 program, they've been much lower. This might have something to do with first-time moms. This issue came up on the call yesterday. But at least when we look at the real data, last year, 2022, 2023, it looks like we're about 2 referrals, or a little shy of 2 referrals a month. If we boost that number, Andrew, I think this one might need an alteration here. A 30% boost on that 2. Oh, that's not 2. I'm using the wrong y-axis here. Sorry, that's about less than half a referral a month. So a 30% increase here, we're probably still a little bit shy of 1 referral a month heading to a substance use service facility, ideally to PCAP. That number needs to be adjusted, I think, Andrew, is that right? Yeah, it hasn't happened yet. Okay. All right, next slide. Objective 3. This one, again, is going to be descriptive because the ETO system just was not equipped to document this well historically. We did the best we could, I think, relying on the referral tracking form again, and looking to see, particularly in those follow-up referral tracking forms, did we have some recognition and some indication that the service referred was actually received. These are the data we see for Sooner Start. And the feedback we've received from you all for several months now, and it came up again yesterday in the learning session, is that we were really motivated. It just wasn't something we were keyed in on documenting. We asked it. We definitely asked it in our sessions, but we don't always document it, and there wasn't a good structured way of documenting service receipt. When we found it, this is what we see. Now you've got the colors here change a little bit. Red bar is C1, green bar is PAT, blue bar is Safe Care. And so we're not seeing a whole lot of documented service receipt for C1 for whatever reason in the system. For PAT, it has fluctuated a little bit. It looks like it spiked in 2020, but it's coming back down and it's relatively low. So room for improvement, at least on the documentation side here of service receipt. Safe Care had 1 year that really spiked, but it looks like there weren't that many referrals that were issued. You can tell by the size of the dot how many referrals are going out. And so if the dot is really small, it means, well, there weren't a lot of referrals that particular year. So anyway, again, room for improvement, we think, and that's why we're largely treating this objective as descriptive. How well do we do collectively over the next year with this new system in place and with this concentrated CQI focus on referrals to these types of agencies? Next slide. I'm not going to belabor the point here, but here it is for legal use. We see a little bit better performance here for all three programs. Safe Care, for whatever reason, these legal services seem to be documented as being received more often than the other two. PAT kind of hovering in the same ballpark as what we saw for Sooner Start on average. And C1 off the floor here, but again, not very high, at least in terms of documented receipt. Next slide. Substance use, PAT and C1, I'm sorry, PAT and Safe Care. In recent years, at least, a lot of documented receipt of these services when those referrals are issued. Not a lot of referrals going out for C1, as we saw a few slides ago. And in those cases where a referral did go out, we're not finding much indication of service receipt. Next slide. Okay, objective 4. We're having to rewrite objective 4 because we were a little surprised, pleasantly surprised by the data in this baseline report when it was put together several months ago. You've seen this before. I'm just going to run through it one more time for refresher. In the top panel, these are the data prior to the pandemic. In the bottom panel, you see data after the pandemic, so during the pandemic, essentially. And in the left-hand side of each of those panels, you see 3-month retention. In the right-hand side of each of those panels, you see 6-month retention. So these are each, these bars, the height of the bar is a percentage retention for either 3 months or for 6 months. And the red bars are families without a particular type of social need that's been identified, at least not documented. The green bar are those where that need was identified and a referral was made. And the blue bar are the families where the need was identified and the referral was not only made, but there's documentation of receipt. We see a very similar pattern here across 4 key social determinants that we're paying attention to. This is financial assistance, as you see on the left-hand side. So for those that had some kind of referral to financial assistance, if it was identified and a referral went out, whether it was received, documented receipt or not, we're seeing a boost in retention for both 3 months and for 6 months relative to the rest of the client population. Same pattern in the next slide for food assistance. The numbers are going to change slightly, but the pattern is roughly the same. And you're going to see it again when we move on to the next social determinant, which is housing assistance. So if that need was identified and the referral was made, higher retention at both 3 months and at 6 months. And then finally, transportation assistance, we see the same thing. So we found this pleasantly surprising, and I know we talked about this in the monthly calls that led up to today's learning session. But the idea that identifying these needs and getting these families connected to services can actually boost their retention in these programs. We feel like maybe we're on the right track here as setting this as a prioritized goal over the next year for your CQI work. The rewrite we need to do is to recognize that, hey, when we identify these needs and make referrals, there's already a boost in retention that exists. And so now what we're hoping is that for the program on the whole, if we can identify more families in need and get more of those families referred to these services, that the program itself will see a boost in retention. And so that's what we're going to track really closely over the next year. We're going to particularly be interested in families that were identified with some of these needs, had a referral but no documented receipt. What happens to them this next year if we make a referral to LASSO or PCAP or Sooner Start and we do see that they've received that service? Are there any differences in the retention rates? Okay, I've taken way more of my time, I think, than I deserved, but that's sort of the motivational background, right, to the innovation project and the pursuit of the UniteUS web portal system. Before we move on to hear about the PDSAs that you've developed, and plan to attack here in just over a week. We want to circle back to one of our referral network partners, PCAP, because it's one of the newest kids on the block. And we know that we've had some several conversations about where do we even get started if that were to be the concentrated focus of future PDSAs. With the afternoon breakout session in mind, we would like you to entertain the possibility of PCAP being your focus come January for the next PDSA. And we have some comments to share with you about the screening process that you might want to engage in order to enact a change idea for that program. So Dr. Fleming is with us, I think, and she's going to run us through a really quick slide presentation on the evidence base behind brief screeners for substance use.
Thank you, David, for getting me started. Good morning to everyone. Before I get started, I want to acknowledge we'll be talking about this for about 15, maybe 20 minutes. We just have a couple of topics we thought would be useful to review and think about some recent statistics in light of the opportunity to refer to PCAP. As I get started, I want to acknowledge I had a cold last week and I still sound kind of bad. So if I cough during, I apologize. I have some tea with me, so I might take a break for that. All right, I'm going to put some slides up on the share screen. All right, is everyone seeing that okay? Okay, thank you. All right, so, and I'd be remiss not to acknowledge that Dr. Deshay played a very important and instrumental role in getting these slides together. And in fact, we'll get to see a recent article that she published. So we'll be talking about substance use screening. And specifically, we're going to go over prevalence rates of substance use and how the COVID-19 global pandemic impacted prevalence. We'll talk a little bit about barriers that caregivers might experience to self-disclosing their substance use. That's an area I know you all are well acquainted with. We want to just go over what research has identified as some of those top reasons. We're also going to talk about the benefits of screening for substance use, why that can be an important step to take in the care you provide. Because screening is important, we'll talk about various assessment approaches and why it's advantageous to use a validated screener. And finally, we're going to introduce one screener that we find to be really useful that we would recommend you to consider for your agency. It's called the UNCOPE. But first, let's dive into some of those prevalence rates. And I'll acknowledge these are some heavy statistics, but they bear witnessing. So this is from a CDC report that's fairly recent. And it was focused in on folks during pregnancy. And they found that about 20% of women in their first trimester report current alcohol use, and that about 11% engage in binge drinking, so drinking enough to qualify as a binge episode. Additionally, moving on later into the pregnancy, they found about 1.4% of women in their second and third trimesters also report drinking alcohol. Taking all that together, about 40% of pregnant women who drink alcohol also use other substances alongside the alcohol use. The most common two are tobacco and marijuana, often because they're perceived as safe by that user because they are legal. And a consequence of that I think is an important statistic to think of is that, oh, thank you, yes, Katie, including vapes. And feel free to pipe in, Katie, if you'd like, or others with knowledge in this area or with questions. And then in Oklahoma, an infant is born with symptoms of withdrawal from a substance every 25 minutes. So we're certainly seeing the consequences of that. All right, we're going to talk a little bit about Oklahoma rather than the CDC focusing more nationally. So in Oklahoma, the rate of prevalence rate of substance use has continued to rise in the past decade. So every time it's been measured, it's a steady increase. And to put that into another perspective, There was a study done by SAMHSA that found 8 to 10% of adults in Oklahoma, and that kind of transitional age of 18 to 25 years uses illicit substances. Other statistics that we have that unfortunately put us in higher rankings is that Oklahoma is in the top 10 states for heroin use and pain reliever misuse in this 18 to 25 year age range. And Oklahoma is in the top 10 states for methamphetamine use across all age groups that they assessed in the study. Overall, Oklahoma is ranked second among the states for substance use disorders. And according to the Oklahoma State Department of Health, 12 Oklahomans die every week from unintentional overdoses. Zeroing in for a moment on marijuana use, especially since it was legalized medically here. This is an article published by Dr. Deshay, which is very exciting, and her colleagues looking at marijuana use among pregnant Oklahomans. So they analyzed tests of blood, urine, and meconium of newborns at 2 sites, the Children's Hospital here and the Comanche County Memorial Hospital. And they were able to compare kind of pre and post legalization. So they compared 19 months before and 19 months after. And in that comparison, they found a significant increase in tests for the active substance of marijuana, the THC, in newborns. Additionally, they also found positive tests for amphetamines, barbiturates, benzodiazepines, cocaine, alcohol, and opiates. So kind of across the gambit of substances. Dr. Deshay, anything you'd want to add about this research?
Nope, you've got it.
Okay.
Now, I will say somebody had asked yesterday about, couldn't you have gotten a hospital in eastern Oklahoma, like around Tulsa? Katie, I'd be happy to send you that paper. We had tried to recruit 5 hospitals and all, including children's, to Connie. Yes, I'll make a note that you'd like that paper. So we tried to get 5 hospitals to participate, and we couldn't get St. Francis's agreement to join the study. We were going to also have St. Anthony's here in Oklahoma City, but they ended up having a problem not being able to provide all the data that we would need to do the analysis. So that's how we ended up with just the 2 sites. But at least we were able to compare the urban versus rural, and we did see some differences with actually some higher, not statistically higher, but descriptively higher rates in the rural settings. So anyway.
Sure. In a way that I'm sure was clinically meaningful, even if not statistically.
Right.
Thank you, Dr. Deshay, for that addition. And I'm excited that folks in the collaborative are excited about it. Dr. Deshay does really cool work when she's not with us here over in the MIECHV side. In addition to being able to look at the kind of pre and post of legalization, there are also some papers focused on the pre and post of the COVID-19 pandemic. And the takeaway overall is that we did see that the COVID-19 pandemic had a negative effect on substance use insofar as that it increased it. Here are just 2 recent studies that we wanted to give you some statistics on. The first was very recently published, and it was looking at mothers who had current or recent active substance use during pregnancy. And again, they compared a pre-pandemic cohort compared to one that they considered kind of during and post. It was from 2020 of January to 2021 of April. And they found between these cohorts that fentanyl use increased from less than 1% to 12%, that tobacco incidence doubled, and that the incidence of preterm birth increased from 48 to 58%. Another study looking at just over 7,000 pregnant individuals in Canada during the pandemic also found increases in use. They found that of those folks, about 7% used alcohol, about 4% used cannabis or marijuana, and about 5% used tobacco, and just under 3% used multiple substances. So we know that substance use is increasing and that it's a very real struggle affecting the families that we serve, and that it has only increased recently with the legalization of marijuana and with the COVID-19 pandemic. So we want to discuss barriers that the people you work with might experience in disclosing that substance use to a care provider. A really common reason, and one that I think many of you endorsed in that anonymous survey last time, was that women fear losing custody of their children and facing criminal charges as a consequence of their substance use. Others might choose not to disclose because they feel they have that substance use under control. They might also simply lack motivation to quit, and they might see disclosure as a step toward quitting. They might see the use of substances as a very important coping strategy to them that they don't want to give up. They might be using it to treat other symptoms, such as reducing nausea during pregnancy with marijuana, or be worried about physical consequences, such as for folks who smoke tobacco, a fear of gaining weight if they did reduce their use. There's also, of course, the very real emotional and internal barriers of experiencing shame and guilt around substance use, and a fear of letting down trusted others if they become aware of the substance use. Some people might not disclose because they lack knowledge of the risks, so that they underestimate the importance of getting that help. Others might believe that if they are engaging in less substance use, so light drinking and smoking, that that's actually okay, or that their preferred substance isn't harmful, so they don't need to disclose it. And still others might manage the stress around disclosing by substituting what they might see as a more dangerous substance, like a methamphetamine, for a substance that they view as less dangerous, like alcohol. A little bit more on those perceived barriers. Sometimes caregivers are actually getting conflicting advice, and this can even come from their providers. So one study found that they could get conflicting advice between their obstetrician and their primary care physician, so far as that their OB might understand morning sickness. Excuse me. And marijuana use to manage that. Others might, again, fear that judgment or being stigmatized for their substance use. They might lack or they fear that their health provider is not encouraging or sensitive, and so they don't want to disclose to them. Or that if they disclose, so by revealing that substance use, it's going to bring out coercive or authoritarian interactions with their provider that they don't want to experience. There's also that fear of bias for those that are seeking substance use treatment. That, in addition to the fear of having their children's taken away out of their custody, that they would be separated from their children if they need to go into treatment. And that they might lack social support from family and friends to make that treatment possible. They might be trying to protect other substance users in their home. Or they might simply be prioritizing more immediate needs. And so substance use is kind of going on the back burner because they're really focused on ensuring they have safe shelter and that they have food. All right, so let's talk about the benefits of screening. So again, we know substance use is happening in Oklahoma, and we know that it's hard for families to report that. So if we screen for it regularly, there are a lot of great outcomes we can see. One is that it allows for early detection and treatment, and the sooner you can get treatment, the better. Another great benefit is that you all are uniquely situated in your home visiting models, that you already have a trusting relationship with this client, and that might be much easier than with a care provider that they're going out to see. And even if screens are negative, if you have a negative screen for substance use, that's a great opportunity to discuss health promotion, to have discussions that lead to great prevention. And overall, this is an avenue we can take to protect children from the effects of substances. Okay, so since screening is useful and advantageous, we want to talk about tools that can be used for this. And one is to say that Intake questions. So what families might fill out initially with you, and you might have an item about substance use, can be useful, but it's not the same as a validated screener. And there are a few reasons why that is. One that we want to highlight is that how questions are asked can affect how people answer. And just one illustration of this, there's lots of research that shows questions that come earlier in a sequence of questions can affect ones that come later. So here's an example that might come up for your families. Do you care about children's health? Most people will say yes. Do you want access to services that benefits children's health? Probably going to say yes. And do you use illicit drugs or alcohol? You might be disincentivized to answer that honestly. Another reason they're not quite the same is that an intake question lacks comprehensiveness. It might miss something because there aren't several items kind of checking for substances. And it lacks flexibility on timing of administration. So an intake, of course, happens usually at that first point of contact. Whereas if you have a validated screener, you have wiggle room on when you administer that and in response to having that good relationship with the family. Here's one really powerful example of why it matters and how questions are asked. So these are results from a study that was done many years ago, but is often used as an example to highlight the importance of methodology. And this was a study that was asking about alcohol use in folks ages 17 to 29 over many years. And so these lines, you see the little years, that's telling you when the data were collected. And then on the y-axis, you have the percent of folks who were endorsing that alcohol use. And they found that they had asked the questions in a different order, in a different style, 1 year. And they saw a very substantial observable difference in reported levels of heavy alcohol use. And so that was attributable just simply to the method of the questions being asked, because they found in years prior and after, when they went back to that same method, that rates kind of held consistent. So let's talk about what makes a screening tool an effective one. Some qualities we like to look for is that it's tested in populations like the ones you serve. So we want to know that it's validated for the folks that you are talking to. We also hope to find that it's reliable. This is a type of statistic we look at where you get the same or similar results on 2 occasions close in time. So if you were to re-administer it, it should still give you similar answers, holding that nothing has changed. What's great about measures being reliable is that if there is then a change in scores, you know that it's probably due to a change in what you're measuring rather than in the question. It's also helpful when they're validated to measure what it's supposed to measure. So that's something else that these evidence-based screening tools go through, is that we look for them to be validated to actually be related to high risk of substance use or high rates of substance use or needing treatment. And that they can measure that completely. So it's comprehensive. You're not going to miss something, and that it can predict other behaviors that might be related to what you're measuring. Again, here being substance use. So with all that, we want to talk about the measure, the UNCOPE. This is an acronym. I can't recall off the top of my head what it stands for, but it's a wonderful measure that's been around for a long time. And it's only 6 items. And it has lots of these qualities we've been talking about. So many studies have confirmed that it's valid across a wide variety of community populations, meaning that we know that this can validly measure substance use in the families that you serve. We also know that it accurately identifies people who need help, and it's been found to do that. That it is reliable, meaning that you're going to get similar results or see real change in it over time. It's free, which is also wonderful, and available in English and Spanish. And on top of it being very brief, only 6 items, and they're simple yes/no questions. We partnered with another state who is awarded the same innovation grant, Nebraska, and their home visiting models. They've been using the UNCOPE for years, and they've developed an administration guide that kind of can cut the time of training. It goes over how do you administer this, how do you score it, and they shared that resource with us. So that's something that we can share with you. Really briefly, I just want to show you what those items are. So this is the 6 items, and it's about the past year. And it's essentially
we might just linger on this slide just a little bit, because yesterday I had somebody say, I would have liked to have read that. So we
thanks
don't
for
have
letting
to
me know.
make
Okay,
it,
I
we
will
don't have
pause.
to make
I'm
it
not
too
going to
quick.
read them to save my voice. I'm going to take a nice big sip of tea while you all read this.
Yeah, so on each one of these questions, you'll ask each one and give them a chance to say yes or no. So you're not necessarily saying, do you have a problem with drinking? But they're saying, have you spent more time drinking or using than you intended to? That's a gentler way of asking something that they may be willing to answer. Neglected some of your usual responsibilities. Felt you wanted or needed to cut down. That can be an indication that there is an internal desire going on there, that they have an awareness that maybe they haven't shared with other people. Has anybody ever told you that they objected to the use? That may be something that they've dismissed that now they're having to acknowledge more openly. Found yourself thinking a lot about drinking or using. Maybe they've abstained during the end of a pregnancy, but now they're feeling obsessed after a baby is born, perhaps. Or have you used drugs or alcohol to relieve the emotional discomfort, such as feeling sad or angry or bored? Back to you, Tabitha.
Thank you, Dr. Deshay. And it has a cutoff, which is great. So they found over years of research with this tool that if there are 2 or more items endorsed yes, that is a good indication to refer that client to services. There's also a brief follow-up question if somebody does answer yes to these items. And it's simply just to try to get an idea of what substances they're using. I want to acknowledge this is not exhaustive, and there are all kinds of new slang and terms and items coming across. Route of administration is also important. So screeners are still screeners. They're just a simple tool. And of course, folks will get more comprehensive evaluation once they are connected to services. So your job is to get them connected there, and then they'll learn more. All right. So just to summarize what we've talked about this morning. One is that we want to acknowledge that vulnerable populations become more vulnerable when substance use is present. This is an important risk factor that we can't ignore, especially because the prevalence in Oklahoma continues to increase and truly represents a real struggle for our families. It's also important to recognize there are several barriers to disclosing, and families might not know where to turn. They might not know how to get that education on how it could be harmful. And that lack of education could be making disclosure all the more difficult, and thus making it harder to get connected to services. And that you all as home visitors, you're in a very unique position to be able to offer acceptance and help for those using substances because you're going to be somebody with a trusted relationship where you can be there and be able to screen for this. And that if you use the UNCOPE, it's a simple, short, validated measure that can be used to screen for a wide variety of substance uses. All right, so that is it for us today. If you're interested in any of the references we included, we're more than happy to send them to you. You can reach out to Dr. Deshay directly or myself. I know lots of you are interested in her groundbreaking recent publication, which she will be excited to share. Thanks for spending a little time with me this morning, though, talking about this.
Thank you, Tabitha. Good job. Questions, comments? Thank you, Connie. We're happy to provide this to you. What I was struck with in putting together some of these slides is the wide number of barriers to disclosing. That was really striking to me. That the list went on, and I could have listed more, but so, and I do think that having you know, you're already trusted enough to let into their homes. And so your agencies are in a unique position to be able to make a difference, which, you know, you do all the time, but I mean, in this particular area. All right, so now let's switch gears and go over to talking about your PDSA stories. We wanted to hear in some more detail about your experience so far, the things that we don't measure with quantitative outcomes, you know, what your lived experience is with Unitas and preparing this initial PDSA. So I'll just share my screen real briefly. These are the programs represented today. We have Oklahoma City Children First, the Parent Child Center of Tulsa, which has PAT and Safe Care, Parents as Teachers, Frontline Solutions, and PAT in the Oklahoma Public Schools, Oklahoma City Public Schools. So I'd like to start first with a presentation from Oklahoma City C1. Hi, Sarah.
Hi, good morning.
Good morning.
Let me share my screen. Let me get to my thing here.
Thank you.
See, I gotta
and the rest of you might
click
go
through all
ahead
my
and queue up.
buttons.
The rest of y'all might queue up your PowerPoint presentations. So I'll come to PCCT next. So take it away, Sarah.
Okay, let me share my screen here. Okay, can you see that?
Yes, ma'am.
Okay, perfect. All right, so let me get over here really fast. I can't see my little thing very well here. Here we go. Okay. All right. So working with Unitas, we decided to work with Sooner Start. And unfortunately, some of our data, which I think most people who were working with this had the same issue that, you know, Sooner Start hasn't been on Unitas, and so we haven't been able to refer through them. But then this is just a little bit of kind of what our process looks like in referring to Sooner Start, and then hopefully what that process will look like once they are on Unitas for us to utilize. So here's our change theory diagram. I won't go through all of these pieces since they'll be kind of in the next slides, but just for you to see that laid out right there. So with our plan, talking about, you know, the tools and resources that we've prepared, one of the first things that we did was just making sure that all of our nurses had a Unitas license so that they were able to utilize the application. That kind of took us a while to get that done, but we finally got it done where everyone had access to that. One of the things that we also tried to do was just when we weren't able to utilize Unitas to refer to Sooner Start was just reminding our nurses to utilize Unitas for other referrals. I know a lot of our nurses definitely utilized it with looking up different resources and things like that. And we did have some of them that actually referred through Unitas and used that process. So that was good to kind of have some experience with that. And then another thing that we were doing as well as we've been partnering with some of our community health workers and social workers for some of our other non-nurse referrals, things that are going to be happening outside of what our nurses are doing. So that's been helpful to us as well as we've been moving through this process. So the actions that we took, we met with Kayla Woodbury to do a training over Unitas for all of our nurses, just so that they would be aware of how to utilize that platform. And then recording our data, our plan was to record all of that with an ETO. We have different touch points available to be able to see where that data is coming from and when those referrals are made, even though we haven't been able to utilize it in Unitas. We are actually able to look in ETO and see when there's been referrals made to Sooner Start. So this is kind of a little bit of our process of what it looks like, determining if someone needs to be referred to Sooner Start. So essentially the process starts with administering our ASQ, and we have different time points that we do that, which that'll be in another slide that we'll talk about. So we will do the ASQ and then review those results with the family. And if there's any concerns that we notice, or if, the parent has any concerns with the child, then we are able to obtain a agreement with the client to be able to make that referral. And so then we make the referral. We will also send a copy of that ASQ to the child's PCP just for that continuity of care, so that they're aware what's happening with the client and their child, and so that they can keep up with that as well. Then after that, once we've done that whole referral process, following up with the client just to make sure that they've heard from Sooner Start. If they haven't, then we can follow up with them and kind of make sure all of that's working out. Monitoring Unite Us, thankfully, like I said, all of our nurses have access to that, as well as our supervisors and myself, and also our office support as well has the ability to utilize that. And so we have actually utilized Unite Us for referrals to our C1 program for different other things, where people have referred to us. And so our office support staff has been able to get into Unite Us and accept those referrals and do what we need to do with those. So that's been good. And so then kind of like we talked about, when are the screenings done? We have kind of an indicated time frame that we utilize through the OSDH guidelines. And so typically about 4 months, 6 months, 10 months, we can do them every 2 months, but we have a set schedule of when they're supposed to be done within our work. Or if we notice that there's any concerns, then we're able to do that ASQ as well. So our outcome measures, percentage of children birth to 2 years of age with positive home visitor administered ASQ3 or ASQ SE who are referred to Sooner Start using Unite Us, who schedule a family interview. So that was kind of what we were looking at, not just that the referral was made, but that actually that there's a family interview that happens in that process. So the denominator for that, the number of families with children under 2 with developmental concerns who are referred to Sooner Start and Unite Us, and then the numerator, number of families who schedule a family interview. So how we can get that information. Process measures, percentage of these children's families who are successfully referred to Sooner Start. And then same thing with that, the denominator is the number of families with children having developmental concern, numerator, number of families with Sooner Start referral and Unite Us. Disruptor measures. So with this, looking at percentage of clients who refuse a recommended referral to Sooner Start, which, certainly parents can do that. Another big thing that we have is just the inability to complete an ASQ with a family, whether that's because we've had a missed visit with them and then we're outside of the time frame where we can complete that, or if there's a crisis that's happening during that visit, obviously that's going to take priority over the ASQ. And so sometimes that pushes those things off and we don't have the ability to actually complete the ASQ. Or sometimes we've left it with the parent because we want them to look through it and complete it. And then, it might not get done. And by the time we come back, same thing, we're outside of that range of being able to do it. So those are some of the disruptors. Our experience with Unite Us, like I said, we had limited experience just because Sooner Start unfortunately wasn't on Unite Us. We have had at least 6 referrals since this PowerPoint was created. We've had more referrals than that made to Sooner Start in just the traditional method where we've either called and made the referral or they have an online form that can be filled out. So we are completing our ASQs like we're supposed to. We are identifying when children need to be referred. So that's the positive, looking at all of that. The other thing too, I know for sure that we did have one referral to PCAP and one referral to LASSO that we utilized Unite Us for. And I know that our nurse that had some of those issues happening with one of her clients found it really easy to utilize Unite Us and navigate that, especially with consent forms with the client and all of that, that it was helpful to have that platform. And then also during this time period, we had one of our nurses who unfortunately moved on to bigger and better things. So we did lose one of our team members. But that's kind of an overview of our experience so far. And we're hoping to be able to utilize Unite Us more in the future, especially as, you know, Sooner Start gets put in there. So.
All right, great job. Thank you, Sarah.
Thank you.
Questions or comments for Sarah?
I have a real quick one, Sarah. That was excellent, and looking forward to your experiences with Unite Us. You may know this already, and it might be worth actually asking directly our Unite Us rep this afternoon about the possibility of also sharing those ASQs with Sooner Start. So you can upload those into the system if you've got an ROI for it.
Yes. And I think the last meeting that we had, I think that maybe Kayla told us that we did have the ability to do that. So yeah, I think that will be great.
Yeah, that's a great point, David, that if others didn't hear that, Sooner Start would like a copy of your ASQ. And so when we get online with Sooner Start a week from tomorrow, fingers crossed, you should be able to send that as an attachment, and the attachment will be encrypted. And so the data will remain secure. So it will be treated that way. All right, thank you. Let's turn to Stacy Slimp from the Parent Child Center of Tulsa. Stacy, are you ready? Oh, you're muted.
Sorry about that. Good morning, everybody. Okay, I'm sharing my screen here. Can everyone see this?
Yes, ma'am.
Okay. So to move something, sorry. So our PDSA story, so this is a collaboration from both of our programs here at Parent Child Center. So it would be Positive Parenting and Safe Care. And so our SMART aim and change theory. So our SMART aim was to 85% of our clients who have been identified with a possible legal concern to be referred to LASSO via Unite Us platform. So our change theory was that we would make referrals through the care coordination portal. Some of the possibilities would be the client refused the screening, or if they did not refuse the screening, we would present the iHelp tool to assess further needs. So that kind of identifies any income support needs, healthcare access, education or employment needs, landlord, tenant, housing, personal family safety, and stability. So that's what the iHelp stands for. And that tool was also provided from Legal Aid. So we would screen all clients within the review period process for possible legal needs. So after we completed that, if they did, the possibility would be that they could refuse the referral. So even if there were needs identified, they could say, no, I don't want the assistance. If they did say yes, then we would refer them through the Unite Us platform. Some things that could happen with clients with legal needs did not qualify. So we had a high Hispanic population who were undocumented. And so even though they might have the score where they need the assistance, they would not be provided that assistance due to legal aid's requirements. And then Unite Us improves their care coordination is our outcome. So our plan step, what tools or resources have we used to prepare? So we need copies of the LASSO brochures and the iHelp tool and provided that to all of our parent educators. What actions did we take? So Unitas provided a training to our team. We got all team members registered to use the Unitas platform. We also did an additional training afterwards because I think originally just getting familiar with the platform itself and getting registered was kind of overwhelming and a process. And so I think, then learning how to go in and make referrals and follow up on those referrals. So we did an additional training with Kayla. Plus we had two new, about 4 new parent and educators. So it says, where were your program record data for the outcome process and distribute measures? So the analyst set up a touch point in ETO for parent educators to record their outcomes. So we called this the new PDSA touch point. Once the referral was made, it was also recorded in the referral tracking touch point, identifying whether or not they needed follow-up. Our due step, so all parent educators will attend training with the Unitas web portal in March, which we did. Administration will make copies of the iHelp tool and the LASSO brochures to provide to the families. Review the iHelp tool and LASSO brochures with parent educators. Parent educators show client the tool and brochures. They'll screen all the clients. Excuse me. For clients with legal questions, so the parent educator would complete a release of information form with the client if there wasn't one already completed in Unitas. The parent educator will enter a referral into, for LASSO into Unitas and document also an ETO tracking, referral tracking. They will complete the PDSA touch point and then follow up in Unitas and ETO to determine whether the client scheduled an appointment. So some of our outcome definitions, basically the outcome measure is out of the clients identified with a possible legal need, that would be our denominator. The percentage of them who were referred to LASSO is our numerator. Process measure is that we screen all of our clients within the review period for possible needs. So this is all done during intake process. The denominator is all clients seen during the review period, and the numerator would be clients who were screened during review period. Our disruptive measures, so if the client refused to be screened, if the client refused the referral, or if clients with legal needs who did not qualify. So like I said before, kind of some of those that were undocumented. Some other observations, so we had a high level of staff and leadership turnover. So we had, we were without a director of our department for a period of time. New Safe Care program manager, which was myself. So I've only been doing this since June. And then we had 4 new parent educators, 2 for each program that joined our teams. We also have bilingual parent educators. They were resistant in referring undocumented clients to LASSO. There was some feelings expressed with Dr. Bard about how they would go through that whole screening process and then kind of feel disappointed, like, oh no, we can't help you, you don't qualify, and so they were using some kind of offensive terminology. And so some of our parent educators were resistant to making referrals to them or completing the screeners. And then just challenges navigating Unitas itself. So that's it.
All right, thank you, Stacy. Comments or questions for Stacy? She brought up an important point about the undocumented clients. There are situations where undocumented people can be assisted by Unitas if they are in a domestic violence situation, if they are in a human trafficking situation, and so forth. David, were you going to say something along those lines?
It was, yeah. Yeah, and yesterday we had flashed on the screen a document sort of detailing instances where labs have cancer clients that are undocumented. So at some point, maybe we can do that again. I don't remember who had that document now, but I see Pilar nodding her head yes. But it's an important topic, and you know, the preparatory work that this group has done and others have been very helpful in sort of shining a light on that potential gap. And I know that LASSO wants to do everything they can for these clients if possible. So we want to explore every option before we close that door. And even despite some of the difficulties in past referrals, definitely not something we want to give up on.
I would
No, I
definitely ask, oh, I'm sorry.
I was going to say, Pilar, if you want to talk for just a few minutes about the undocumented clients and how they can receive help.
Yeah, I would like to speak to that. As we first started doing some referrals, I know for a fact that one of our intake persons were refusing to even do an intake on anyone that was undocumented, and they were turning people away. I was not aware of that until later when I received a complaint, and we put a stop to that. Because this was somebody out of Tulsa that was doing this, and I was not aware of that. So this was happening at the beginning. That has since been corrected. They have been retrained. They are not to ever tell somebody that they're not allowed to make an application. Michael, our director, had to speak to them very in strong words to say, no, you do not ever tell somebody that they cannot complete an application. So in this grant or any other type of applicant, everyone is welcome to always do an application. Whenever somebody is told that they cannot receive services, only an attorney, after being reviewed by 2 attorneys, can they be told, sorry, we are not able to assist you. And even then, we try to provide them with other resources, or at least minimum advice. In this grant especially, we want to try to assist as many people as we can, at least with legal information. The only caveat to that would be in a conflict of interest. That is when we truly cannot do anything, because we would be violating that conflict of interest rule, and that they could be disbarred for something like that. The attorneys could. But outside of that, we will always try to find a way to make it work. So please give us another chance. The problems that we had initially have been resolved. Our staff has been retrained. And if you ever have any issues with any of your referrals, please call me or email me, because I am your resource for any situation that happens. All your referrals should have at least an application made. And if you ever run into any issues, questions, or problems, you call me directly. If I'm not available, you call Michael directly, because we are here to make sure that everyone has access to an attorney.
And I do want to clarify, Pilar, thank you for bringing that up. And yes, it has been one of the things I think we mentioned to Lisa was that we do have that direct communication with you, and that there's any questions that you have been very helpful in following up on that. And there, I do want to clarify too, that there have been success stories with undocumented clients that have received services. I think it's more of a personal, like you said, I think Dr. Bard mentioned there are specifics to that. So it hasn't been a complete, you know, with all of them. Those are just some of our discrepancies there.
And something we heard yesterday was that we can be very cautious in how we talk to undocumented people about their chances. We can say they may not be able to take you as a client, but they have information that could help you. And so they may be able to make a referral or tell them, here's what you need to do first. And so they can, without becoming their attorney, they might be able to help.
Yeah, I do agree that I think they've become aware of the situation, and thank you, Pilar, for filling us in on some changes that have been made and stuff. So we're excited to continue to pursue that.
Yes, I agree. Pilar's just been a terrific partner. Thank you, Stacy, for discussing this with us early on so that we could help get some things taken care of so that this problem does get relieved and we can get help for this vulnerable population. All right, let's take a little break and come back at 10:40. Okay, let's get back to our PDSA stories. And next, let's hear from Frontline Family Solutions. Hi, Amy.
It's me. Good morning.
Good morning.
Let me share my screen too. View it as our slideshow. All right. Well, we are Frontline Family Solutions. I guess we are loading still. Here we are. Get started. So we serve Garvin, McLean, Comanche, and Southern Cleveland counties. This is our 50th year in operation, which is amazing. So I'm proud to be part of this team. Let's see. So I guess we're just going to jump into the presentation here. We started August 1st, going to end December 31st. The key driver we're using is, of course, the Unitas platform. We want to simplify and improve the referral process to Sooner Start. So 100% of the children identified during the review period with concerns or delays based on either ASQ model will be referred to Sooner Start using Unitas. As of today, I do not believe we have any referrals submitted yet, but we are ready to do it. So the supervisor, which is Deidre, and the staff is going to be implementing these changes. We will use Unitas to make the referrals to Sooner Start, like I said. The activities, in the screenings can take place during the in-person, virtual, or group visits at our offices or the family's homes, just during a typical visit. So what have we done so far? Well, we've all had ASQ trainings to learn how to use the screening tool. We've had several group meetings about how we're going to implement these changes. We've taken Unitas training. We've worked with you several times during the rounding calls to kind of narrow down our process and make some modifications to our plans. So targeted for the change, of course, is the workers at Frontline, our PAT staff and supervisor. So what we have prepared for the parents is the Sooner Start brochure that we were able to get at the home visitor conference. We did meet with them one-on-one during that resource booth, and they were able to give us some brochures. So we really like those brochures to kind of introduce Sooner Start to the parents when we're beginning to have those discussions about the referral. The ASQ handouts from the ASQ screening guides. We use the CDC milestone book that we used in the last CQI project. We're continuing with those. The Sooner Start referral form, the release of information, and we're still using the Why Screenings Matter handout that we used in a previous CQI. We have implemented that. So to do it well, we had some getting access and the training for our staff on Unitas.
I hear it on your laptop, but I don't hear it on here.
We'll clarify who's responsible for entering referrals. So that is going to be our office assistant. She's going to handle all those direct referrals through the Unitas platform and monitor those for all parent educators. Obtain the tools needed, which are the screening guides, release forms, the brochures, any information that we need to present to the parents. We will screen the children, obtain consent to make the referral, and then enter their referral in Unitas. So when a parent educator completes the developmental screening on the child, we use two different methods. The first one is asking the parents the question and getting the response from the parents or the child demonstrating the skill. We can ask the parents to elaborate on some of those skills. The second method, completing the developmental screening, is used with completing the developmental screenings. If a parent would like to work with the screenings before a visit, we can make sure that the parents have all of the supplies prior to our arrival so that they can be prepared for that screening event. And then after completing the screening, the parents are advised that the parent educator will review the results, and we will repeat necessary and follow up with the appropriate referral source with those outcomes. Each family is reminded of at their previous visit that an ASQ will be completed at the next visit. So they are aware that it's important to keep that visit and to have time set aside for that screening to occur. Families are also aware of the required time points and completing the ASQ3s and SEs at the time of enrollment. If an ASQ is positive, we want to introduce the Sooner Start program to the family. So we have any material provided to the family about Sooner Start and the delay. We want to have that prepared. We do share the score sheet with the family to let them know where their child is landing at on the score sheet. If the parent agrees to the referral, the recommended referral will be sent to Sooner Start through Unitas. Like I said, our coordinator assistant will be putting in all of the referrals to the Unitas program. The parent educator, like I said, again, she's going to have them complete the release of information, permission to exchange form. The parent will submit the ASQ results, the Sooner Start referral form, and the permission to exchange form, all done through Summer, our coordinator. If the parent declines to be referred, we will continue to monitor their progress. And after referral has been made, we will document the attempts to that all documented attempts to contact are in Unitas. If the referral seems stalled or there have been multiple unsuccessful attempts, we will check in on the family to see if any further assistance is needed in completing the referral and offer to be with the family during the time of the Sooner Start appointments. Just another layer of support we're going to implement during that handoff process. And after a successful contact or assessment has been completed with Sooner Start, the PE will check in with the family about their experience with the call or just at the next home visit. This is a copy of the Sooner Start brochure that we got from Sooner Start that we're using. Again, the ASQ information. These are examples of what we're going to be using just amongst PEs for the referral to Sooner Start that we're going to submit with our ASQs to Unitas and the permission to exchange information form to complete. So we want to measure the percentage of children with an identified concern or delay referring to Sooner Start using Unitas. Our denominator will be the number of families with a child under age 2.5 having an at-risk range on the ASQ. The numerator is the number of families referred to Sooner Start using Unitas. So we are going to be measuring those outcomes as well as the percentage of children who schedule an intake with Sooner Start. Similar method there. So the percentage of children with a visit during the review period who received the ASQ screening is our goal, that we want to have 100% of at-risk children using Unitas and the referral process. Some barriers that we've identified is that the parent may refuse to have the child screened, the parent may refuse the referral, or the parent accepts the referral, but then changes their mind and refuses the services. So that's just 3 that we've identified. Normally, we identify more as we go, so we are open to seeing how this plays out in the next few months. Here again is just some measurements that we're going to be tracking. Again, more tracking methods for if they decline services. We have received referrals through Unitas. 2 of the 3 referrals were looking for senior citizen care, which we don't offer. So that was just a confusion maybe in the beginning, getting everything set up. And the 3rd referral was for someone already receiving services to our program. So we are glad that it's working and we're starting to get out there a little bit, a little more comfortable and confident in our skills with Unitas. So we are excited to expand using Unitas and receiving referrals as well. So that is kind of where we are at. We are launching. We are ready to go with it. If you guys have any questions or suggestions, we're glad to have them.
Great job, Amy. Thank you. Any comments or questions for Amy? Congratulations on your 50 years. I was just looking at events from 1973. The Watergate hearings were going on. Their Secretariat won the Kentucky Derby that year. The Sears Tower in Chicago was being finished. Lyndon B. Johnson died, and Skylab was launched. So so anyway, that's an interesting Wikipedia page if you want to go Google 1973 events, and you can see how far you've come. All right, very good. All right, now we're going to turn to Oklahoma City Public Schools. I don't know how to pronounce your name. Is it Malika? Are you going to be presenting?
Yes, I am.
Okay, did I pronounce it right?
Yes.
Okay. Yolanda is, everybody knows her bright, shiny face is usually here presenting, but she has put off a vacation for over a year. And so she finally got to take a vacation. And so Malika, thank you for stepping in to present.
Yeah, no problem. And so we also worked on Sooner Start, and like others have shared, that we did not have a chance to use Unitas with Sooner Start.
Okay, do you need me to share the screen or?
Oh, sorry. I thought I was.
Oh, okay, thank you.
Hold on 1 second.
Okay.
I'm looking at it. You're not.
Yeah, we're your psychic friends watching it with you.
Can you see it now?
Yes, we do. Thank you.
Okay, perfect. Okay. And so here is our theory timeline here to incorporate referrals, outcomes with the data to use into Unite Us, identifying children under 36 months using our developmental screenings that have risk or concerns. And then we'll kind of talk about if a parent refuses referrals, referring families to Sooner Start, using Unite Us system, families successfully connecting with Sooner Start and scheduling assessments, families complete a Sooner Start assessment, and proving ways to refer families using Unite Us. And so our planned step here, so the tools, like I said, we'll use our ASQ3 and ASQ-SE, which is our social emotional developmental questionnaire within Unite Us. And I just learned that we could share that to Sooner Start through Unite Us, which is awesome. And then actions taken. Parent educators have been informed during staff meetings and reflective about the new system to refer families to Sooner Start, and letting program supervisor know if the child is under 36 months, and identifying the potential delays or with any developmental concerns. Program supervisor has taken initial training on to implement the referral process to Sooner Start in the system. And the program records the data, required outcomes, process, and disruptor measures. Program will record data in UNITA system and ETO for referrals, and disruptors will be recorded only into ETO. And then our do step, we'll use the ASQ screenings as our tool for all enrolled parents and teachers programs at certain intervals. And so it kind of breaks down to their age groups or whenever needed. And we'll kind of see where their developmental, if they have developmental risk, where we, parent educators will provide referrals for further assessments with the primary caregiver's consent. If the child scores in the gray area of our screening, parent educator will provide information and more activities for the development in this particular area, such as motor development, social emotional, gross motor, things like that. And actions taken would be to implement this program, this project, where the program supervisor will use UNITA's care system to refer the child under 36 months of age to Sooner Start for further assessment. The referral will be entered into ETO and for annual reporting and parents as teachers and all that good stuff. And we'll need to create or blah, blah, blah. Program supervisor has been granted access to UNITA system and initiates a brief training to start the referral process. Parent educators will continue using ETO referral tracking, touchpoint referrals. The program supervisor will monitor UNITAs and report back to parent educator as needed. And then here it has our intervals of when we do the screenings. And then the ASQ screening SE is for annual use for each child. And then our outcome measures the percentage of children with an identified development concern who complete a Sooner Start intake and assessment. The denominator number of families referred to Sooner Start using UNITA's, numerator number of families who completed the assessment. And then we have no data at this time, as I shared earlier, we did not use it. The process measures, same thing, it's like. And then our disruptors, again, kind of like a family refusing the referral to Sooner Start. And then an issue, I can't see what it says on the top. Issue we might run into is family does not qualify for Sooner Start services. Number of referred families who are screened by Sooner Start and deemed ineligible. Denominator would be number of referred families who are screened, and a numerator would be the number of families who are ineligible. A family declined services, number of referred families who are eligible for Sooner Start services, and numerator will be the number of referred families who decline to engage in services. And then lessons learned. And during this process, the implementation of the UNITA's care system will improve the process for referrals and coordination across agencies. We're tracking the steps, actions, and updates of the referrals and the outcomes. And then again, we don't have any data showing this process. And this is just our director of early childhood information, Yolanda's information, and then our educators listed here.
All right, thank you, Malika. Any comments or questions for Malika?
I did have one observation. From what I remember from Sooner Start, do they not have a cutoff of 36 months? Like, that's when their services end? They can no longer serve children after they turn 36 months? Is that, am I
Yeah,
remembering?
that's right. That's
Yes,
right.
yes.
They are limited, and so they may even back that up to, if they don't have time, if they're coming up on that 36-month mark, then if they're 34 months, they might not have time to do anything substantial with the child. So there is a time there where they wouldn't be able to take the child as a client because of the child's age.
Yeah, I think they said it would take a couple of months to even do the initial assessments or
That's
something.
right.
Yeah. So
Mm.
in our case, and I don't know if this is statewide, but if the child is at that age point, that we refer them to our child find program with the public schools. And so it's not like they won't get any services at all, but outside of Sooner Start, we refer them to child find.
Oh, that's good. I didn't know about that. Thank you, Malika.
You're welcome.
Other comments or questions? Yes, great job, Malika. I agree with the comment. David, would you like to make any comments before we break for lunch?
Just that I share the excitement about the PDSAs that you guys have in place. Anxious to get those kickstarted a week from tomorrow, and more information coming on that particular date, and customized forms that are being built and embedded within Embracer right after lunch break. So hope you can be here. Our Unitas representative will join us for about an hour and a half. And we're going to run through another demonstration of the system, and she'll be available for a Q&A on the tail end of that if you have any specific questions about how your PDSA is going to work once this is live.
Yeah, one of the custom forms is going to be very short, and that's going to be the ETO case number. And you'll put that in, and it won't go to wherever the referral is going. It'll only be in the background so that we'll be able to take the Unitas data and match it up with data coming from ETO. And so we can see what's being recorded in each system. And so to do the dashboards for this current PDSA. And the other custom form is what I mentioned before about the program engagement mile markers. And that's a longer form. And she's not going to be able to show us exactly what that form is going to look like because it's being created at the moment. And that's what should be done by a week from tomorrow, we hope, fingers crossed. But she's going to show you an example of a custom form and how you can go in and add information, and how the referral partner will go in and add information about attempts to contact and so forth. So that's what we're going to do. We'll go ahead and take a lunch break early because Kayla is not scheduled to join us until she starts her presentation at 12:30. So I will leave my connection to the meeting room up with this reminder on the screen, and we'll just see you back here at 12:30. Thank you, everybody.
Thank you.
Hi, everybody. We're going to be getting into the breakout room soon, and I wanted to mention to you who will be in which room. There'll be one for each of the home visiting agencies here today. Now, C1, Oklahoma City C1 has been working with Shalan, and she will continue to be your analyst. But but she is out of town today, and so I will be working with you in the breakout room today instead. For Oklahoma City Public Schools, your analyst is Adam. Now, Frontline also has Adam as the analyst, but because Adam can't be in two places at once, Andrew Peters is going to be working with you in the breakout room today. And finally, for PCCT, Yachi is going to be your analyst, and so she will be meeting with you in the breakout room. So, David, would you like to talk about the next PDSA?
Yeah, just briefly, because I want to make sure that you get plenty of time to work on this next PDSA. I know it seems a little strange to be building a new one right before you start your current one. But as I said yesterday, we sort of happily, accidentally stumbled into this process because of the contract delays, getting all of the relationships in order that we need for this project. And we like the extra preparatory time that you've been afforded for the current PDSA. So we're going to try to replicate that with the next one. So timeline, just so that you were all on the same page. You'll start your current PDSA now if you haven't already. And as Kayla said in the last portion of our session, those customized forms should be active a week from tomorrow. You'll work on that PDSA up through the end of this calendar year. And I know, historically for us, around the December timeline, a lot of you sort of hit the pause button right before the holidays. That's perfectly acceptable, understandable, and would make a ton of sense because come early January, we're going to meet again for our next learning session. And we'll ask you to present the findings of the PDSAs you've developed to date at that session. So there'll be a couple of weeks there where we'd like you to be working on your final presentation, and hitting the pause button sort of naturally would occur at that moment. When we show up for that learning session, you will have had a giant head start on this next PDSA. In fact, it probably will be a near final version when you show up. And we'll work with you not only in today's afternoon breakout session, but in the monthly calls and the rounding calls between now and January to put the finishing touches on these. So for today, we're sort of dipping our toe in the water here. We'd like you to focus on the P part of PDSA. So as Lisa mentioned, she has circulated the PDSA template document to all of the groups. We'd like you to fill out the portion that corresponds with planning. If time permits, and it did yesterday for many, we'd like you to move on and also work on some of those do steps, particularly how you'd like to screen for identified need. Because that tends to be where a lot of us, where a lot of the conversation and development needs to take place. So having that initial conversation today, we think would be fruitful. And then in the months ahead, we can polish that portion of it up. It's not necessarily part of the P, but to get to P, you got to have your SMART aim developed. So we would like you to spend some time initially working on the SMART aim. Don't get too caught up in the numbers at this point. I'm going to bounce around from each room, and I'll probably have some ideas to share with you on the topic of where to set your improvement benchmarks. And a lot of that's going to be anchored by the data we saw early this morning. But SMART aim, if you would, we'd like to have a version of that drafted for today. The outcome, the process, the disruptor measures, at least a general idea of what you'd like to capture. You don't have to have necessarily the numerator and the denominator fully ironed out at this stage, but an idea of the what you'd like to capture for those three concepts. If you have the time and the ambition, a change theory diagram is going to be asked of you very soon, so you could even start to sketch that out together today. It's sort of ought to drive really your planning phase anyway, so it's going to be in the back of your mind. If you have time to jot one down, that's great. Don't spend too much time on the beautification of it. If you would, put a sketch together, get it to our team. We'll certainly help you put that in slide presentation format. And that is something we're going to revisit at, if not the next monthly call, the one after that. Okay, I think I'll stop there. And as I said, I'm going to bounce around from every room. You're going to have an analyst from our team though with you, so feel free to lean on them for advice or even just as sounding boards, and they can help do some of the drafting of the document too if needed. But without further ado, I think Lisa Tunley, I'm going to turn it over to you, and we can open up those breakout rooms.
Did you say that that you'll be moving on to one of the they'll be moving on to one of the programs that they have not done?
No, I did not. Thank you, Lisa. Yeah, so just a reminder, I know we did talk about it in the last couple monthly calls leading up to today. We're asking you to move your focus to another one of our referral network partners for this next PDSA. So if you are focused on Sooner Start currently, we ask that you now focus on either LASSO or PCAP.
I also want to add that we have representatives from LASSO and PCAP on today. So analysts, if your agency is focusing on that, you can pop back into the main room and grab either Katie or Pilar or anyone else representing those programs to pull them in to answer questions and assist.
Yeah, and just based on yesterday, some helpful feedback, perhaps. A lot of the folks that chose LASSO for this upcoming PDSA incorporated that iHelp screening instrument. So we've got dozens of people on the call right now who can easily put that in your hands. If you want to look at that as you're having this conversation about how you're going to introduce the conversation with your clients, that seems to be an integral part of those PDSAs. Same may be true for PCAP PDSAs and that uncope measure from this morning. So we could Tabitha could try to get that in your hands quickly as you think about how you're going to approach clients with these questions and make decisions on when a referral is pertinent.
Okay, I think now, Lisa, we're ready for you to open up the breakout rooms and just scroll down and choose for your home visiting agency to join that room.
Okay, here we go. If you need help getting in the room, just let me know. I'll put you in there.
Well, how'd that go? Seeing a few nods. I'm seeing some thumbs up. That's great. All right, what I'd like to do now is to go around and have each of the programs talk for just 5 minutes about what you think you're going to do on the next round of PDSAs. You can just talk a little bit about your SMART aim and a few details about your plans. And any of the more interesting parts of your discussion that came up, things that you weren't expecting to be thinking about. And the analysts can share their screens to show what you worked on today. So since I was in a room, I'll go ahead and go first. I'll share my screen. And Sarah, are you here?
Yes,
There
I'm
she
here.
is. All right, here we go.
Okay, so we discussed that for our next project, we're planning to work with referrals to LASSO. And essentially we just borrowed some information from Tulsa C1. So we'll give them some credit here in this room and then credit to their faces as well when we see them. But so our SMART aim is 85% of clients identified with legal concerns during the review period who agreed to a referral and are referred to LASSO via Unite Us. And so one of the things that we went through and talked about with this process is creating a screener, which Tulsa C1, they already kind of have a screener available that they utilize to ask clients if they, needed any legal resources for different reasons. if they were having any particular issues. So our plan is that we will complete that screener at least one time for each of our clients within this time frame. And then if it's determined that they need referral for legal services, then we'll complete that referral and unite us to LASSO. Other thing, disruptor measures, we talked about that. Different reasons for the screener not being completed, just if for some reason the client is, we're unable to reach them, or they, have a crisis that's happening or something like that. There's various reasons, but hopefully within this time frame, we should be able to get through those things. And then another disruptor would be the number of clients who turn down the offer for the referral to LASSO. So one of the things that I thought was important that we talked about as well, and I can't remember who brought this up, if this was Lisa, or maybe I think just through a combination of things, or maybe Susan said this, but we talked about kind of creating a script for introducing the idea of legal services and this information, just for it to be clear to clients why we're discussing this topic, and also how we, might be able to refer them for services that can help them. And yeah, just being able to kind of have a clear conversation around that, not that we're screening to see if they've got a bunch of problems that we can get them in trouble for or anything like that, but just screening to see if they need any added resources. So that's kind of, I think, the main thing. Lisa, is there anything else that you want me to add with all of that? Do you want me to go through all of the other pieces?
I don't think you need to go through all of it. You brought up, I think, an important point of having a script for introducing the topic in a way that isn't threatening to the client, because you do deal sometimes with people who are undocumented, and that can be very sensitive to bring anything up. So there may have to be a different approach, as one of the other programs did for their PDSA, of having, I think it was yesterday, they were talking about having a separate script for opening the discussion with people who are undocumented, saying, I know that you have a lot of challenges being someone who's undocumented, but there are ways of getting help if you're having any concerns about you're feeling safe in your home, that you can gently bring up the idea, is there domestic violence going on? Is there human trafficking going on? Anything that would qualify them for services, as opposed to someone who is a citizen, of being able to say, let's talk about your housing. Do you feel secure in your housing? Are you having any landlord problems? Or different ways of talking to different people. I thought that was important. So is there anything else that you would like to talk about with about your project?
I don't think so.
Okay, thank you.
Thank you.
All right, who wants to go next? Lena, would you like to go next?
We'll work on it. Oh, go ahead, Lena.
Yachi, would you like to share your screen, please? And show the PDSA? Thank you. Take it away, Lena.
Okay. So we're going to improve the referrals to Sooner Start to ensure children's development is on track. Our SMART aim is that all of the qualified children under 32 months who are identified with concerns or delays based on the ASQ will be referred to Sooner Start using Unite Us. Our outcome measures will be that the percentage of clients who identified with concerns or delays are referred to Sooner Start using Unite Us. And then the percentage of clients are assessed by the ASQ. And then our disruptor measures, we had quite a few that we're thinking about, or possibilities. Children not qualified, clients refusing the referral or the screening, or just the services in general. And then parents or children maybe having like that language or cultural barrier. Because at least here in Tulsa, Sooner Start services, I don't I'm not really sure how they are with the like having like other languages. And then we just have the ASQs and then the Sooner Start brochure that we'll use. And then there's the ASQ activities and interventions that are appropriate for that child's age. Our plan. So the parent educators are going to implement the change, and then the children who identified with children who are identified with possible developmental delays or concerns after using the ASQ, and then we'll refer them to Sooner Start through the Unitas portal, and then the activities will take place during the home visit. Or at home visits, and then during the time period, January 24th through May 24th. So our steps are, as of right now, we switched it though. We're going to educate the parent educators for Sooner Start services and clarify the criteria for qualified children. And then they'll complete the ASQs during the home visit, and then review. Sorry, I have a different version over here. I added, so we'll review the results with the client, refer the client to Sooner Start using Unitas, and then go from there. Haven't it up yet, but we're on
You're on a good start.
yeah.
That's great. Any questions or comments for Lena? Anything else you'd like to say about your plans?
Stacy, team, anybody want to say anything?
No, I think we just kind of discussed that we've already kind of had Sooner Start, come out and meet with us at one of our department meetings. And so they've already kind of shared some, information about their services and things like that. So we're excited to start that with them.
Oh, that's great. That's great. You've got kind of a head start in a way. All right. Thank you. How about frontline? Amy or Dee Dee, would you like to go next? And Andrew, you could share your screen.
Do you want to take over, Dee Dee?
There. Okay. Okay, our SMART aim will be 100% of the families with identified need of legal services will be referred to LASSO. Our outcome measures, we will use the PDSA touchpoint on ETO to track whether a client requires a legal aid. And with the item, our question will be, does this family require legal aid? And it'll be a yes or no question. That would be our denominator. And then we will be asking, we will use the referral tracking and the Unitas data to track referrals to LASSO, and that will be our numerator. Every client will receive the handout and answer the ETO PDSA touchpoint items at least once within 60 days of the start of the CQI project. We had a lengthy discussion on this part, how often to do the survey, the tool. Some was saying that we didn't need to do it every month. That was too much. So we narrowed it down to within 60 days that they just do that survey. Our process measure, 100% of the families will fill out the LASSO screening tool. The PDSA touchpoint on ETO will be asked, has this family filled out the LASSO screening tool? Again, that will be a yes or no question. Then our disruptors, we come up with one interesting one. The family is already pursuing legal aid elsewhere, was one of the disruptors, and then being overwhelmed with other concerns. We have financial concerns there. And then we want to do a Dropbox or a text box for our other, and then you would have to answer that other and explain what is the other. We talked about that a lot, so that we can get kind of an idea of different disruptors. The tools needed, we will also need access to and copies of the LASSO survey. So that's the survey that we will be using for this project.
Okay, I can forward a
And
lot
I
of
think-
materials to you, Dee Dee.
Okay, thanks. That's awesome. I think that's all that we got to today. Anybody on the team want to add anything?
No, good job.
I guess by way of
All
explanation,
right,
I'll
very
say that she flagged this one as interesting because I thought it was most interesting. But like, I think all of these are good options for disruptors. Although we were a little unsure about financial concerns, someone pointed out that there's a good chance that that the LASSO services they provide, if they provide them, will do so pro bono. But
I am fairly certain they're at no cost.
okay,
Yeah,
That's the
per-
idea.
maybe it doesn't make sense to ask this one then.
it's possible to encounter court filing fees, but then they can also make a request to get those waived. So that's just if it goes to the level of court and you have to file something, there are fees associated with that.
Pilar, are you on the call?
Yes, ma'am, I'm listening. And yes, that's why I typed back that if we have to go to court, there could be court filing fees associated with filing like a petition for a divorce or paternity case or a custody case. But depending on their financial situation, we could file and petition the court for a pauper's affidavit for the judge to approve that. And that way they can waive the court costs, and then it would be zero altogether. But for LASSO ourselves, there is no cost for representation. It would just be court costs that they could potentially have, but we'll try to get those waived for them.
Yeah, so the judge could put in an order saying we're waiving these fees because of the client's financial needs. Okay, that all looks really good. Anything else you would like to add, Andrew or Dee Dee or Amy? All right, thanks a lot. And I think we just have one left. Oklahoma City Public Schools, Juana or Malika, are you here?
Yes.
Hey, Malika.
Let me share my screen. So we are also choosing to do LASSO, and we had already had like a meeting and discussed everything before Yolanda left. And I'll just read over what we have already. And then the red that you're seeing on here are some things that we're considering adding or that we'll share with our supervisor to kind of see where we'll go from there. And so we decided to choose LASSO to improve the process of making referrals using the Unite Us care coordination portal facilitating system. So between legal aid, which is the LASSO, and Oklahoma City Public Schools, parents, teachers, and our SMART aim is to implement Unite Us system. At least 75% of our clients who have been identified with legal concerns will be referred to LASSO using Unite Us. And we kind of discussed maybe screening all of our families instead of just 75% or whatever. Like, we'll just go ahead and see how they all do with using maybe using the screening with the iHelp. And then also, after listening to Sarah, maybe coming up with a script, I think that would help us out a lot with getting the legal aid information across to our families. And then implementing the change would be our supervisor and parent educators. And the target would be our supervisor, parent educators, and our clients needing LASSO services. identifying families that have legal concerns, which again, we will use the tools that we have. Using iHelp seems like the best choice for us right now. And then implementing that during activities before, during, or after our home visits during that time. And then identifying the families as our step, and then using Unite Us as our tracking system. And I'm sure we'll also use part of ETO referral tracking as well. And yeah.
Yeah,
And
that's
then-
good. We can, during the monthly rounding calls, we can flesh out that do step. The way I described it to another agency is it's like a recipe. It's like if you were having to leave all the instructions for somebody else to do everything, you know, just be a list. Okay, you're gonna have to create a script. You're gonna have to decide on the screener. You're gonna have to make sure everybody on the team knows about it and so forth. That looks good. Juana, did you want to add anything about this discussion? I don't know if she's still on the call. What else would you like to tell us about the project, Malika?
Before I forget, are you able to get some brochures over to us about Lasso?
Absolutely. I just made a note that when I send to Dee Dee and Amy, I'll send you and Yolanda a slew of materials, including the IHOP. I'm getting hungry for
I mean,
dinner.
you can include IHOP if you want.
The IHOPs, yeah, we'll do the IHOP screener.
I also want to hop in and just say we do have a Teams page for this project where all of these resources are already centralized, and that will be sent to everybody before go live.
Oh, okay. Okay, great. Thank you, Tabitha.
The only thing I wanted to add, which we kind of already got a list sent to us of, we have a large percentage of families that are undocumented. And so just keeping that in mind as far as like our script and how we come about sharing this information. And yeah, we kind of have an idea of things that will help our families be able to follow through.
I have an internal Lasso document that Pilar has shared with me, and I also have her presentation from March where she talked about screening people who are undocumented, and I can forward those to you as well so that you can see there are circumstances where people who are undocumented can get services. And so those situations are described in that internal document that Pilar has shared. And so that might help you to develop a script for people who are undocumented. And the iHelp, we also have it in Spanish, so I can send that to you too.
Okay.
So,
awesome.
anything else about your project you'd like to talk about?
Not that I can think of.
Okay. Let me do one thing here. So this has been a long day, and I know these days are always long and everybody gets tired of sitting at the computer. We won't keep you much longer. Dr. Fleming, would you like to make any closing comments?
Sure. Thank you so much, Dr. Deshay. We are so grateful for you all remaining with us and patient as we head ever closer to the go live. So be on the lookout for that email from Kayla and the option for office hours should you like more clarification on the custom forms as you get your staff rolling with that. Everyone did a wonderful job designing their second PDSA. And as I said, all those resources, so referral forms, brochures, etc., for each of our referral partners, as well as the change theory diagram and other resources related to this project are already housed on a Teams account that's under review by the liaisons, and that will be sent to you all before go live.
All right. Thank you, Tabitha. And I want to thank you, Tabitha, for your presentation this morning, Yachi and Andrew and Adam for your help in the breakout rooms. I think among all of us, we've got a really great team, and I appreciate the opportunity to learn from you each time we meet. And so thank you so much. We're going to let you go a little early today, and I hope you have a great evening.
Thank you.
Bye-bye.
Thank you, Lisa.
Thank you.
Bye.